Good afternoon, everyone, and thank you so much for joining today's Healthcare Team Cyber Discussion. And for our first-time participants, we really want to welcome you to this call. We're very happy to have you join us, and we hope that you will join future cyber discussions. My name is Veronica Chalette, and I'm a Program Director in the National Cancer Institute's Healthcare Delivery Research Program, and I will be moderating today's cyber discussion. I would like everyone to know that this session is being recorded. And today's presentation is the first in our three-part series on examining the emerging trends of diagnostic and treatment delays and decreasing adherence to care due to patient financial hardship. So presenters in this series will be discussing team-based interventions they conducted to reduce patient and healthcare system costs while improving team coordination as well as patient outcomes. So whether you're a practicing clinician or researcher, we hope our spotlight on component teams of multi-team systems that are helping patients adhere to treatment by minimizing financial hardship will stimulate some ideas in your areas of clinical practice or research. So there were two articles for our background reading for today that review best practices and models of care that resulted in reducing hospital readmissions and emergency department utilization, and is important for financial well-being of patients and cancer programs. And they were a great introduction to today's presentation. And so for today's session, we are very excited to host Michelle Brusio and Georgina Rogers, both from the Cleveland Clinic. They will be sharing outcomes in an intervention at Cleveland Clinic that utilized an RN care coordinator to reinforce team strategies to reduce hospital readmissions as well as emergency department utilization, resulting in reduced out-of-pocket patient costs. So I do have a few housekeeping items to address before our presentation begins. As a reminder, this session is being recorded. To prevent background noise, all lines are muted during our presentation. However, if questions come to mind during the presentation, feel free to type them into the Q&A or chat panel and press send, and we will read them during the Q&A timeframe. You should be able to see the navigation buttons to select your choice for interacting with us during this session within the WebEx platform. You can also select the raise hand icon found under the participant panel, and we will unmute your line if you'd like for us to, for everyone to hear your question during the Q&A session of the webinar. And if you have any questions or comments at any time during this session and our series, during this session or in our series, please feel free to email us at hctcyberdiscussions@nih.gov. So one last point, please make sure the icon you want to interact with us within the WebEx platform is selected and then use the drop-down option. Closed captioning is available by selecting the Media Viewer panel on the right-hand side of your screen. To enhance interaction with participants and presenters, we've added a few poll questions and knowledge checks for the presenters to respond to using a software called Mentimeter. And to access Mentimeter, you can use any device that uses a browser to access the internet. Okay, so we'll go to Mentimeter first, and then we'll have our first poll question.
So our first poll question for today is who is on the call? And as a reminder, just go to www.menti.com and use the code 216834 visible at the top part of the screen. And we'll keep this poll question open for a few moments. You can use a mobile device to answer the poll questions if you have one readily available next to you. You can also open a web browser on your computer screen if easier. It looks like the results are coming in. And I'll be reminding you of this code as we continue through the webinar. The code will remain the same. And so that website again is menti.com and the code 216834. So it looks like we have mostly researchers on this call, but again, as this is a live polling tool, we'll see this continue to change, and maybe we'll check back as we continue on through today's presentation.
So great. Thank you, everyone, for participating in the first poll question, and we hope you enjoyed today's session. So our two presenters today are oncology nurses from the Cleveland Clinic, Ms. Georgina Rogers and Michelle Brusio. And I'll briefly introduce both of them, giving you a brief bio of each. Georgina Rogers has been the Director of Clinical Cancer Services at Cleveland Clinic's Talwicks Cancer Institute since 2012. She has over 26 years of experience in oncology nursing, with the last 19 years spent in a management and leadership role, and has worked extensively in areas of quality and process improvement, clinical compliance, and patient safety. She is currently the program manager for Cleveland Clinic's participation in the oncology care model, leading teams in enhancing quality of care while reducing the overall cost of care for patients. Michelle Brusio is a manager of care coordination, also at the Tallwood Cancer Center at the Cleveland Clinic. She oversees 60-plus registered nurses, care coordinators on the main campus and 10 regional locations. Michelle has experience in acute care hospital and outpatient, as well as payer case management and care coordination. She is a case manager and will complete her, she is a certified case manager and will complete her Master's of Science in Nursing with an emphasis in care coordination in March of 2020. So Gigi and Michelle, thank you so much for leading today's healthcare team cyber discussion. We're so happy to have you share your research on team-based interventions that you use to reduce hospital readmissions and utilization costs at the Cleveland Clinic. And now I'll turn the session over to you guys.
Thank you. Thank you. Just trying to get my slide to move forward. There we go. So this is Gigi, and Michelle and I are both in the room here, and we'll be kind of switching back and forth as we move through our slide deck. But first I wanted to mention the objectives. So what we hope that you get out of this presentation is an understanding of the work that we did regarding understanding the roles of a care coordinator, the importance of a care team model, some of the strategies that we have attempted to use in reducing hospital readmissions and emergency department utilization, some of the challenges that we have faced and continue to face when it comes to risk stratification of patients, and then determine what potential future research in readmission reduction and risk stratification can be used. So a little bit about the Cleveland Clinic. We are a very large comprehensive cancer center. We have 19 different locations, 4 affiliations. We have greater than 200 physicians that are associated with us, greater than 700 caregivers, and a significant amount of outpatient visits, chemotherapy treatment visits, and radiation treatment visits. And I mention this because we feel that this may contribute to some of the issues that we have with readmissions, emergency department utilization due to the sheer volume and acuity of the patients that we see. And I want to mention, as part of this, we are members of the Oncology Care Model, and if you are not familiar with that, it is an alternative payment model that has been developed through the Center for Medicare Medicaid Innovation. It's a 5-year payment model, and it uses financial incentives to help us support practice redesign or practice transformation. And within that, the overarching goal of the Oncology Care Model is to improve the overall quality of care for our patients while maintaining or especially reducing the overall cost of care to the patient. And what they intend for us to do is use the right care for the right person, coordinate that care, and make sure that our patients have appropriate access to care. We have to abide by specific metrics, and 2 of the huge ways that we are hoping that we can reduce the overall cost of care to patients has been through reduction in admissions/readmissions and emergency department utilization for our patients. So as we move along here, our next poll question is, which of the following evidence-based strategies can assist with the reduction of potentially avoidable ED visits and hospital stays? So watching the poll results kind of come in, and interestingly enough, each one of these potential interventions are evidence-based strategies that can potentially assist with the reduction. And on our next slide, we will take a look at these a little bit further. So same-day access, outpatient symptom management, distress screening, and increasing the hours of operation. For the purposes of our involvement in the oncology care model, we focused on the first three and have not gotten to the point where we are considering extension of our hours of operation, although that may occur at some point in the future. We added personnel to assist us with financial navigation. We added pharmacists, financial navigators, advanced practice providers, social workers, and at the center of our program really is where care coordination comes into play. We expanded care coordination from our main campus location out to our regional operations sites and began to put into place interventions to help drive the readmission and ED metrics down. Michelle is going to talk a little bit about care coordination and some of the interventions that have occurred to help get us to the point where we are today.
Thanks, Gigi. So care coordination. Care coordination is deliberately organizing patient care activities and meeting the patient needs and preferences to deliver the highest quality of care. We take this a step further here in Taussig. We offer our patients dedicated oncology disease-specific care coordinators. This means, for example, that a patient with a thoracic cancer will have a registered nurse care coordinator dedicated to their care who has specific clinical knowledge on thoracic cancers. The same goes for all of our other disease specialties as well. Our radiation oncology care coordinators are also dedicated disease-specific nurses, and our palliative care registered nurse care coordinators support symptom management to all of our patients in Taussig. The role of the RN care coordinator, using the nursing process, the care coordinator assesses our unique patient's needs, barriers to care, and organizes and implements a patient-centered plan of care through a multidisciplinary approach with physician guidance. This multidisciplinary approach allows us to see our patients holistically. Ongoing communication and shared knowledge with the patient and their team is imperative in the delivery of safe, appropriate, and effective care. Our interventions include ongoing education with patient verbalization of understanding by using the teach-back method and motivational interviewing. We provide our patients with resources on their cancer, side effects, and often refer them to other resources like our resource center to work with our liaison who can provide specific resources the patient is searching for. Other interventions include high touch and targeted outreaches, inpatient visits, transitions of care, as well as day-to-day triaging, patient status, and symptom management. Many times our patients need referrals to palliative medicine for symptom management and medication management. They also have nutrition and dietary needs, so we'll refer them to nutrition, as well as social work to address psychosocial needs. We facilitate shared decision-making with our patients that offer the most up-to-date evidence and plan of care, which allows our patients to consider options and treatment that align with their personal preferences. This then allows for us to coordinate advanced care planning. ED utilization. Another important intervention that care coordinators do is keeping patients out of the emergency department through triaging and same-day interventions. However, our data finds that the majority of our patients heading to the emergency department do so during available hours of operation, despite our when to call guidance. Some patients just want to be seen, and some just want to have eyes laid on them. So over half of our patients that arrive at the emergency department are not admitted. They're treated and released. This is where we continue to find whether a patient needed ED interventions or same-day access. Manual chart reviews have unofficially revealed that most patients self-admit to the ED and do not call their provider or care coordinator to discuss symptoms prior to their arrival. So as you can tell from this slide that our readmission rates are up and down. We do have a higher readmission rate compared to others in the oncology care model. We think this is probably because of the many types of cancer that we see, our acuity and volume that was mentioned earlier. So 2019, we ended below target for readmissions, which could be related to some of our interventions. However, we do continue to learn each day more about our populations and what the root cause is of our readmission rate.
So now that we have looked at where we stand currently with readmissions and emergency department utilization, I want to talk a little bit more about some of the strategies that have been put into place in an attempt to reduce both of these. One of the first initiatives had to do with appropriate access to same-day or urgent visits. And we developed guidelines and education for the patients so that they would understand when to call their provider or their care coordinators. And we wanted them to contact us first before heading to the emergency department. And we wanted to have the ability to add these patients on same day for any particular intervention, such as hydration, antiemetic usage, as a stopping point for them so that they would not head directly to the emergency room. And one of the identified issues is that during the regular office hours, for patients who do call, they may have difficulty reaching their provider in a timely manner. And so very recently, an additional project has been implemented utilizing clinical pools in our electronic health record so that there is a more team-based approach. And the hope with that is that patients will have return calls and return interventions in a speedier time frame. Another intervention was working on patient education on symptom management. Our care coordinators do a fantastic job of initial treatment patient education. They provide it in a multitude of ways, face-to-face, through the telephone, and it is continuous. Our care coordinators are tasked with reaching out to patients prior to their chemotherapy to give the patients a little bit of information on logistics, resources that might be available to them, and specific patient services. We also provide our patients with standardized tools and resources. So on the right-hand side of this slide, we worked with our care coordinators and our physicians to provide a general guidance document on when the patient should contact their provider or care coordinator. We also provide the patients with what we call our My Journey binder, and it's a collection of resources for the patient to help guide them through their treatment journey. And then we also have patient portal access through our electronic health record.
So all of our patients meet with us face-to-face to discuss disease process, symptom management, medication management, and the available resources in TOSIG during their initial education. Our patients also receive ongoing education and high touch through our targeted outreaches. We utilize a 48-hour post-discharge call, which follows up with our patients post-discharge. The emergency room follow-up call is done within 24 hours of notification that a patient was in the emergency room. We also developed the Cycle 1 Day 1 call. This is where the patients will get a call from the care coordinator within 7 business days post their first treatment. We also utilize toxicity checks throughout treatment and follow-up touches. We've also recently revised templates or created new templates, and these allow us to assess for symptoms, barriers to care, anxiety, health literacy, and update the plan of care, again, through our multidisciplinary approach. Our ongoing high-touch model allows us to communicate with our patients via the EMR, telephone, virtual visits, and even face-to-face while they are in clinic, infusion, or when they are inpatient. We're lucky enough that we can actually walk over to our inpatient units and visit with our patients to discuss new barriers or revising a treatment plan. They do really appreciate that. We also communicate with our home care agencies, skilled nursing facilities at discharge or post-ED visit to provide them with resources about our unique patients. This partnership has increased communication and continuity in care amongst the team. Psychosocial care. The oncology care model, as Gigi mentioned before, allowed us to increase some social work support here at Maine and within the region. Many of our patients have anxiety, which through data collection has been proven to be a factor in readmissions and ED utilization. Social work with our patients, we utilize them through assessment of depression, anxiety, barriers, social determinants of health. Social work is crucial in providing ongoing support throughout our patients' cancer journey. So you can see collaboration on the screen with community outreach, transportation needs, financial needs, lodging, and connection to support groups and support services. We are very lucky to have a palliative care team to assist our patients early on with symptom management and improve their quality of life. Our program works with our patients inpatient and outpatient. We have 4 full-time palliative medicine care coordinators at our main campus and recently added 3 palliative medicine care coordinators to the region who also work with patients that are at their home. Our palliative medicine program care coordinators play a significant role collaborating with our medical teams on cancer, pain, nausea, vomiting, opioid, constipation, etc., as well as they also are imperative in helping the HEMONC or radiation oncology team to prevent ED visits or readmissions due to symptom management issues. We have several committees that allow us to evaluate ED and our readmission utilization through data and interventions with the goal in mind of meeting the triple aim. The triple aim is improving the patient's experience of care, improving the health of populations, and reducing per capita costs. Our high utilizer committee meets monthly to discuss patients with at least 2 30-day all-cause readmissions within the preceding 60 days. The purpose of this multidisciplinary committee is to develop individual care plans for patients with frequent preventable readmissions in order to better address their complex medical and psychosocial needs, while subsequently decreasing preventable admissions, readmissions, and emergency department utilization. Once the plan of care is discussed with the committee, the care coordinator will then discuss the plan of care, the revised plan of care, with their patient to allow for informed consent and buy-in from the patient. We also have a readmission committee, which is also a multidisciplinary approach to look at trends in readmissions. We discuss the readmission rates per oncology unit, days from discharge to readmission, disease stage, symptom management through palliative medicine interventions, discharge position, which means if a patient goes home to home care or they are admitted to a SNF. We also look at compliance with post-discharge follow-up appointments and outreach. We also evaluate if there's a transitional care gap or a coordinated care gap in this committee. In our practices, we do see a rise in immunotherapy, with distinctly different symptoms and timing of symptoms. So our pharmacy team is actively working at this time on data for immunotherapy patients and how we can better treat those patients with their signs and symptoms. Through the work of this committee, we've been able to work with other institutes to provide education on our unique patients and discuss the current plan of care with our oncology providers. We're also working on educating our emergency room department, home care, and skilled nursing facilities on our oncology patients, on our when to call document, as Gigi explained before, and the immunotherapy side effects. Future virtual visits we're looking into for 48-hour discharge callbacks and a continued partnership with our home care on education of our unique cancer patients. On to continuous improvement. Our continuous improvement methods allow us to meet with our team weekly to discuss organization and institute goals, as well as align our care coordination goals and projects to the organization and institute. We do this by using our visual management boards in problem solving, standardizing workflows, and engaging our team in change or process improvement. This is an example of one of our visual management boards. These boards are team-driven and ran by our caregivers, not management. The boards and processes allow the teams to own metrics, maintain data, problem solve, and increase engagement. It also allows for idea generation and collaboration with our team members and departments. The teams are given dedicated time also during staff meetings to work on these projects. The boards are also reviewed by management a few times a year to assess engagement, the integration of institute and enterprise goals, as well as if their work is meaningful to the specific needs or changes within the group. Caregivers are given dedicated time, again, to work on all of these projects. The Care Coordinator Team Board, for example, meets every Tuesday at 8 a.m. We are currently focused on projects such as an A3 blood bank project. We've created a newsletter and website that will house information specific to care coordination, the Clinical Pools project, which was mentioned earlier, as well as volunteering and engagement. We also will utilize this time for quick weekly team huddles. Care team huddles. Care team huddles have evolved into daily and or weekly huddles. The purpose of our huddles are to increase open communication amongst the multidisciplinary teams. These huddles can be between the physician, APP, and the care coordinator, inpatient and outpatient huddles, as well as larger groups such as physicians, care coordinators, APPs, pharmacists, social work, PalMed, nutrition, and pharmacy, for example. Each patient's individualized plan of care is discussed during these huddles. It can include preventing readmissions, assigning referrals, a discharge disposition, and follow-up care.
And as you take a look at this slide, the 4 quadrants that you see at the bottom of the slide, medical, functional, social, and cognitive behavioral, those quadrants were our first attempt at kind of qualitative measures for risk stratification. We currently do not have a formal risk stratification automated model, and so this care team huddle was to help provide the entire team with potential signals that would make the team believe that the patient would be potentially at high risk for ED utilization or hospital admission. We're going to transition a little bit into risk stratification, and what variables do you think that you would want to include in a risk stratification model?
So for this
as you guys are copying in.
Yep, so a little different with this poll question than our other ones. You can feel free to type in your own answer, again, going to www.minty.com and typing in the code 216834. And again, you have multiple responses if you want to kind of put 3 in, or if you just have 1. And again, for anyone who might have joined us late, using your cell phone device or your computer, feel free to go to minty.com and type in the code at the top of the screen. So it looks like we have a few responses coming in. Feel free to add in multiple ones if you'd like, and we can always also come back to this slide as people populate with answers.
So I'm going to move past the slide and we can actually go back, but I'm seeing a lot of some of the common things that we also had put into our initial model, and you'll see that on this next page. We had a pretty large list of items, comorbidities, metastatic disease. We were looking at age, different disease types, psychosocial support, history of delirium, homelessness. And we wanted to validate the qualitative quadrants that we had developed to make sure that we were on the right track. So what we did is we did a chart review of 69 patients that were part of our high utilizer committee. And of those 69 patient charts, 68 of them had unplanned admissions. And what we did find with this small sample size is that our top items were evidence of comorbidities, metastatic disease, history of mental illness, and substance abuse, tobacco specifically, were the highest indicators of risk for our patients. Now, subsequently, we have worked with a biostatistician within our department, and he did an audit of, I believe, 6,000 to 8,000 points of data, and was able to even further validate that we were on the right track. And one of the items that we did not specifically have in here that is the #1 contributor to emergency department utilization is, in fact, anxiety. So our hospital system does have a readmission risk calculator embedded within the electronic medical record. And we would love to use this predictive model to proactively identify our patients who are at risk of poor health outcomes. We want to be able to identify them and provide targeted interventions to them so that we can improve care management and keep them out of the hospital, thereby reducing their overall cost of care. This risk calculator, while it works great in the primary care setting, unfortunately for oncology patients, it tends to flag all of the oncology patients as high risk. And so we need to develop that further, and we're just not there yet. We want to be able to assign a risk status to each of our patients, and through risk stratification, of course, you can use clinical intuition, the aggressiveness of current treatments, known complications, disease stage, social determinants of health, data-based algorithms. So right now we're working with what we've got. And so it continues to be an offline qualitative huddle until we get to a more advanced risk calculator. There are some tools that were newly implemented to try and assist with identification of patients who have had frequent readmissions. In our electronic health record, there are some new columns that can kind of call out whether or not a patient has had a readmission within 30 days. It can also display the number of days between the last discharge and the current admission. There are some new alerts that are available and in-basket staff message notifications to providers to give them information that their patients have been admitted. And when we finally get to where we want to be, there are huge benefits to risk stratification, especially for the care coordinators. It's not a one-size-fits-all approach. They may have a large panel of patients, and we want to be able to very accurately determine which of those patients are going to need increased touch points and which of the patients could have less frequent touch points because they are, so to speak, cruising along. If we can determine the relative risk for our patients, we're hoping that we can decrease the cost of care for them. We can individualize their patient care. We can prioritize the interventions that we're using for them, and through real-time risk stratification, provide appropriate assessment and interventions for the patient. So there have been numerous interventions, numerous deep dives into the data, multiple teams working on different initiatives, and we continue to do so. And in the future, we may continue to look at what predictors may be for 30-day unplanned readmissions. Are there specific clinical or non-clinical factors that are driving those readmissions? We really want to get to that oncology-specific predictive risk model for ED utilization so that we can create interventions, whether the patient is of low, rising, or high risk. And we're also looking at pharmacy data because as new drugs and treatments come out, they may have different side effect profiles. One in particular are the number of immunotherapy medications that have been coming out have much different side effect profiles than your typical chemotherapy. And so we are now taking a look at some of those drugs and regimens and working on algorithms for management of those side effects, education to the patients, and education to the nursing teams that are caring for those patients.
So what's next for us in care coordination? We'll be working with our pharmacy and physicians, as Gigi mentioned, to focus on immunotherapy symptom management guidelines, ongoing education to our patients, home care agency, and emergency departments to call us first before they go to the ED and discuss a plan. We'll also be adding, as I mentioned before, 48-hour discharge callbacks. The addition of clinical polls also will allow us to get back to our patients faster with interventions and referrals. Enhancing transitions of care to decrease fragmentation of care through huddles and better communication of the plan of care. We will continue to standardize documentation templates to ensure our patients' needs are met. Ongoing role delineation also will allow to ensure that we all are working to the top of our licensure and improve quality of care. What's new for the Institute? There is work going on to analyze data and determine if an oncology-specific readmission calculator will be useful to our patients. We'll also be reestablishing a formal APP-led urgent visit clinic to see more patients that need same-day interventions. This, again, will allow us to avoid readmissions and ED visits during business hours.
And with that, that brings us to the close of our presentation.
Great. Thank you so much, Gigi and Michelle, for your great presentation and for sharing with our listeners the opportunities, challenges, and successful team-based strategies for reducing hospital readmissions and emergency department utilization. And congratulations on the work that you're doing at the Cleveland Cancer Clinic to reduce hospital readmissions and emergency department utilization. So I do have one question to start off our question and answer session. We do have several clinicians on the call, and I was just hoping if you could expand a little bit more about the challenges that you might have encountered in identifying high-risk patients.
Well, we started out with, we got an entire team together to take a look at and our first guess at what we thought would be potential reasons why a patient would be high risk. Barriers are, it's hard to extract a lot of this data from our particular electronic health record. We felt a little bit better about our initial assessment once we worked with our biostatistician because he was able to basically reinforce and validate that even though we don't have an automated or electronic process, that we were on the right track for the items or factors that would contribute to a person being potentially high risk. But what's missing and what continues to remain a barrier is that it's without having automation to this or a list that the caregivers can use. It's really putting the onus of determining who's high risk back on the care coordinator. And then we currently don't have very specified guidelines to distinguish between a rising risk patient versus a high risk patient. I think it's easier to determine, okay, you've got a low risk patient, we're going to follow up with them every 2 weeks. But when you get to the rising risk and high risk, what's the magic number of touch points, interventions, office visits to help keep them out of the emergency department?
Great, thank you for that response. And I had another question in regards to the home health care that the patients were receiving that are part of Cleveland Clinic. Is that home health agency a department within Cleveland Clinic, or is it an outside home health agency? And if so, were there any barriers to collaborating with personnel at the home health agency in regards to teaching patients about their symptom management and helping the home agency to manage that so that the patients would not have to go to the emergency department?
So we do work very closely with our Cleveland Clinic home care with symptom management, but our care coordinators also are tasked with calling any home care agency that a patient may be supported by in order to speak with them about the unique patients, their signs and symptoms, to be on the same page of when to call us. The barrier is just, I think, being on the same page and really understanding the unique needs of our cancer patients. So that's where that when to call document and our My Journey book have been two focuses of us discussing with the home care agency so that they can take a look at signs and symptoms a patient may have post-treatment, what their schedule looks like for chemotherapy, when to expect those signs and symptoms from the day of treatment, as well as being on the same page that, hey, maybe instead of just assuming that the patient needs to go to the emergency department, that we call the care coordinator or the provider first, and be able to set up a plan of care, which, you know, definitely will help the patient not having to come in, decrease those costs for the patients, as well as the overutilization of something that we could manage either at home or here in the cancer center.
Great. What about the symptoms? You mentioned the primary symptom for emergency visits were anxiety. And I know you did capture others, but I'm just wondering whether or not there were a lot of symptoms not even related to the cancer treatment that you were just tracking the readmission, but the readmission, the cause of readmission had nothing to do with symptoms related to chemotherapy or radiation or other types of treatment.
So interestingly enough, yes, when we're capturing the data, there are going to be some patients that we're tracking that have emergency department visits and hospital admissions that are completely unrelated to their cancer diagnosis or cancer treatment. You know, for example, the patient that got into a car accident and ended up in the emergency department.
Mm-hmm.
But by and large, the patients that are heading to the emergency room and being readmitted are being readmitted for cancer-related symptom management needs. And we're trying to dig a little bit deeper into the specific disease groups, and that may help us to drive further symptom management. So for example, stands to reason that our genitourinary cancer patients have a high incidence of hematuria, which is sending them to the emergency department. And so does that mean that we need to do a better job of educating the patients, or the providers in the emergency department, or their caregivers at home on at what point they should be concerned about the hematuria?
And so with those symptoms that are not related to the cancer treatment, I'm hoping that does not impact reimbursement through the participation in the Oncology Care Model Reimbursement Program.
Unfortunately, it can. So we are responsible for, if it is a cancer patient with a cancer diagnosis on treatment and they are within their 6-month episode within the oncology care model, regardless of what sends them to the emergency department. We are on the hook for that.
Oh, no.
Yeah. So we kind of chalked it up to we can only control what we can control.
Right.
And kind of go from there.
All right. So we do have another question. I'm not sure if the person might want to raise their hand so they can ask the question audibly. The question is, were you able to compare the prevalence of those variables among non-high utilizers? The person who asked the question, can you raise your hand or re-enter the question in the chat box or the Q&A panel? So while we're waiting, I want to talk a little bit more about the readmission risk calculator. Are there any calculators specific to cancer patients that you're aware of?
There are, at least not within our health system, there are no current risk calculators available.
Mm-hmm. Okay. All right, so the person declined to restate the question. Let me see, were you able to identify? So my question that I had prior to the call, but I think you did answer it, is were you able to identify the planned readmissions versus the unplanned readmissions? Were you able to categorize those who were coming in for chemotherapy and surgery versus the unplanned, whether or not those were related to symptom management, like fever related to chemotherapy or chemo-induced nausea and vomiting?
Yes, thankfully, we're able to kind of carve out the planned readmissions for treatments.
Okay, great, great. Well, we don't have any additional questions coming in. So thank you again to you, Gigi, and Michelle for a great presentation, and thank you to our participants for joining us today and for participating in our poll sessions. Just wanted to let you all know that we will be having another session focused on this same topic on May the 26th from 12 to 1 p.m. And our featured presenter is Dr. Margaret Liang, who's assistant professor at University of Alabama in Birmingham. And the title of her talk will be Evaluating the Early Impact of Adding a Financial Counselor to an Oncology Care Model Pilot Program. And you can register for that session now, and the registration link is shown to you on this particular slide. And we do have a few minutes before 2 o'clock, so I hope you guys will take time and complete the online evaluation that will appear on your screen when the session closes. We do appreciate your feedback. They're very valuable to us, and they help us improve future cyber discussions. So again, thank you everyone for joining us today, and we hope you enjoy the rest of your day. Thank you again. Bye-bye.
Thank you.